Now, basically, the beautiful article about vitamin D deficiency in a sunshine country, because sunbathing is a taboo in India because of dark complexion. So there are many factors there getting responsible for osteoporosis in India. Now there is a concern of increasing life expectancy, and probably by 2025 we expect all average life expectancy going above 70 years of age. So we predict that almost above 60 years there will be more than 50% population who will be osteoporotic. Now whenever there is a bone, see, serum calcium value is a very critically monitored value in human body. So if we are low in vitamin D and then the bone resorption starts, uh, because we need to maintain serum calcium value, the bone resorption starts, there is an increase in bone formation. But unfortunately in osteoporosis, there is an increase in bone resorption, but very poor bone formation. So the remodeling effect of major bone concern in weight bearing does not occur because of osteoporosis. Now, there are additional causes to enhance osteoporosis other than postmenopausal osteoporosis, sedentary lifestyle. It's alcohol abuse, excessive smoking, gross vitamin D deficiency, inadequate physical activity, because it is known that with increased physical activity, there is a good remodeling of the bone, low calcium intake, high salt intake, excessive, like those who are thin, it's more common to have osteoporosis, excess of vitamin A, and sedentary lifestyle. Now, there are additional factors like genetic disorders, hypogonadal states, endocrine disorders, most common being diabetes and thyroid issues, gastrointestinal disorder, excess consumption of PPI, then hematological disorders. All rheumatological patients like RA, Angspong, all have osteoporosis. Parkinson's, stroke, COPD, and patients on anticoagulants, which is very common. Rheumatoid arthritis patients on methotrexate. Most of these patients show evidence of osteoporosis later in life. Now, how do we diagnose osteoporosis? Osteoporosis can be it can be diagnosed on clinical suspicion. Then on physical examination, BMD assessment is the most reliable source. Vertebral body imaging was an older technique, but still carries um, edge over other imaging modalities like calcaneal indices and wrist indices. Vertebral indices are still very relevant, and biochemical markers for bone turnover, which are gradually increasing. Now, over a time, there is a increase in dorsal kyphosis. So, a simple test called wall test, when you ask the patient to stand touching buttocks and the dorsal spine, they are able to touch their head to the wall. If they are unable to touch their head to the wall, then probably they are developing increased dorsal kyphosis. Rib pain, pelvic girdle pain, shin pain, osteoporotic patients also have heel pains. These are the areas where maximum pain is seen. Now, multiple myofascial triggers also is a common feature of lethargy, um, loss of self-esteem. There are all things which occur in osteoporosis. Bone mineral density, like BMD, is a very standard test for osteoporosis. Ultrasonic scans and all are very unreliable. BMD is very reliable. BMD has two issues, Z score and T score. So they are compared to the gross population available across your age group, and second is basic bone mass index. So you get bone mass, you get T score as a representative, like minus 2.5 below is definitely osteoporosis and needs treatment. Also, we calculate the bone mass, like bone density. It's one bone density is the optimum. So whenever lesser that, like 0.6, 0.7 reading, so we can grade our osteoporosis. Now, what are the indications of BMD? To whom you should advise BMD? Number one indication is, once you have diagnosed osteoporosis, you would like to do BMD every yearly to understand what was the bone status of that individual for 1 year. But when you recommend BMD, women above the age of 65, men above the age of 70, with clinical risk of fractures, if they are young postmenopausal women, men between 50 to 60 age group with a high clinical risk of fracture, then other comorbid conditions patient should be undergoing, or if the patient has another evidence of a fracture like a low velocity wrist fracture, these should be subjected to BMD on regular basis and they should be treated more aggressively. Now the two areas of interest in BMD is what is the bone density in the spine and what is the bone density in the proximal femur. So these are the two areas of interest for osteoporosis. Now, vertebral imaging is a good predictor of osteoporosis. Like we have a dense bamboo tree forest. So when we pass a light, the light is obstructed through the bamboo tree forest. So when you remove few bamboos, the light will be passed. So coarse trabecular pattern is the first sign in a good quality X-ray to assess about vertebral osteoporosis. That's a very early diagnostic sign. By the time vertebral body collapse occurs, it's a too late sign, but increasing trabecular pattern is the first sign in vertebral imaging. Now, as a routine, vertebral imaging should be done in all cases complaining of back pain in those who are above 60 years of age. So they should get a good quality of a lateral view of dorsolumbar spine, and we should concentrate on the transitional zone vertebra, that is a D12 vertebra and L1 vertebra. So we can calculate the amount of coarse trabecular pattern and predict that this patient might be having osteoporosis. Now there are increasing biochemical markers for osteoporosis like CTX and NTX, and also bone specific alkaline phosphatase is gaining popularity. Now, most of these markers are done prior to administration of drug and after the administration of drug. Isolated marker turnover for diagnosis of osteoporosis has a less clinical significance. Now, WHO has given some risk factors which we have partly discussed, like current age, gender, prior osteoporotic fracture, femoral neck, BMD, low BMI, glucocorticosteroids, rheumatoid arthritis, smoking, consumption of more than 3 drinks like 180 ml per day, then parental history of hip fractures, then secondary causes of osteoporosis should be on red alert. Now they have a calculation tool, questionnaire, to assess what is going to be a fracture risk for next 10 years. So we can download these forms or we can get it through the industry, and this can be a very good tool to assess what is going to be a fracture prediction for next 10 years. Now additional bone densitometry technologies in pipeline like CT based absorptiometry. Then one more marker coming on MRI also, on a functional MRI marker, this trabecular bone score. Then peripheral dual, like in the DEXA, we have a peripheral DEXA, and then quantitative ultrasound densitometry is improving now. The current ultrasound which industry brings to most of the doctors, it's relatively unreliable to diagnose osteoporosis. Now in management there are general recommendations and pharmaceutical recommendations. Now the number of osteon can be improved, or remnant osteon can be ossified by giving adequate dose of calcium and vitamin D. Now current recommendations are increasing now. So we are recommending 2000 milligram per day as 2000 international units per day vitamin D and 1000 milligram per day of calcium. An average Indian diet where consumption of milk is a tradition in India, in any other form like curd, yogurt, paneer, taking tea, we have adequate calcium intake actually. We take a lot of vegetables in our food because that may be a problem in Western population. But the issue is only vitamin D. So vitamin D is very important. It should be started at very early age, like all pediatricians should start vitamin D because most of the kids are also vitamin D deficient. They get valgus. Nowadays you will see a precarious puberty, valgus axis of the knee. They are all due to low vitamin D in childhood. Then exercise has a major role in prevention of osteoporosis. Both isometric, isotonic exercises are very important for prevention of osteoporosis. They increase bone mass. Secondly, now there is a current issue which is likely to crop up in next 10 years is sarcopenia. Sarcopenia is definitely goes hand in hand with osteoporosis. So in treatment of osteoporosis, even treating sarcopenia is very important. Like our protein intake should be increased to at least 1 gram per kg body weight, which prevents sarcopenia. In turn, it prevents loss of muscle strength and osteoporosis. Then fall prevention exercises are important, like stereotactic exercise, wobble board exercise, running on a moving board, and of course that's for everybody. Avoid tobacco and have excess alcohol, but have alcohol but excess alcohol. Now, population-based strategies to prevent osteoporosis, like exercise, calcium, dietary calcium, these help in treating osteoporosis in a broad way. But we need pharmaceutical therapy when patients have low DEXA, they have previous evidences of fracture, or there is an increased probability of fracture for 10 years probability calculated by Frack's algorithm, which is available by WHO in a format. So what are the pharmaceutical guidelines currently today followed about bisphosphonate, calcitonin, estrogens, then raloxifene, then tissue selective estrogen therapy. Of course, estrogen, raloxifene, tissue specific estrogen therapy is limited to female gender, and then PTH, parathyroid hormone analog, teriparatide. They are retrieved out of E. coli, and they have a anabolic effect. Now, previous medication like Stromba and anabolic steroid, which is very popular, it does not help in majority. It increases protein intake. If it is added with protein intake, it might slightly increase bone mass. But like Metadec and all those kind of injections, they are very less helpful in pharmaceutical therapy of osteoporosis. Now, the current guidelines is first-line agents like alendronate. Alendronate has got a largest base of prescription, and their side effects and all are known. Alendronate, a word of caution for alendronate is that it increases gout pain. Alendronate increases gout pain. So if your patient complains of two things like esophagitis or increasing body ache after alendronate, you should not give them alendronate. Then the second, alendronate, residonate and zoledronic acid is the first line therapy. Nowadays I am seeing a lot of excess bisphosphonate consumption by patients and having fractures due to excess bisphosphonate. So we have to be cautious that most of the patients are given zoledronic acid, and then they are also, now they go to other doctor and also they are taking oral bisphosphonate. So this combination should be absolutely no. Then calcitonin is gaining popularity. Calcitonin has two sources, bovine and porcine. It is given nasal spray and injection. Nasal is very, it's a convenient to give nasal calcitonin. Now, whenever there is a vertebral fracture or any other fracture, calcitonin plays major role. Per se, for osteoporosis, calcitonin goes low in line. Then if 6 months of conventional therapy is not effective, then teriparatide should be given. Now there are newer agents in pipeline like denosumab, then strontium. They are all on trial and they have shown a wonderful clinical significance, but it's another 5 years down the line that we'll have assessment of reduced fracture abilities. Then we have data now where patients had one hip fracture not treated, sustained another hip fracture for 5 years. Now they were on strontium and now they have not had this. So we are trying to understand about variability in these studies which is available. Now very gaining popularity that it might change the scenario of osteoporosis, anti-sclerotic antibodies. These are very, they will have a lot of implications about biologics in osteoporosis, where we have already biologics in rheumatoid arthritis. Then parathyroid hormone related protein, that's also gaining popularity, like teriparatide. Abloparatide is gaining popularity in clinical trials. Now, abloparatide has definitely shown increased bone mass, BMD, as compared to teriparatide, and it's about more than 50% decrease in the fracture possibility in abloparatide than teriparatide. Cyclopamine A inhibitors are also gaining popularity. They are basically major osteoclast derived proteolytic enzymes in the bone. They are they will increase bone mass at a faster rate. So genetics is also important for osteoporosis assessment now. In conclusion, osteoporosis is associated with significant morbidity and mortality, like with newer trends of anesthesia, good medical care, and quick surgical care. We are trying to reduce mortality in elderly age group, but still there is a 10 to 15% mortality. In past decade, the mortality has dropped down from 35% to 15%. So we need to, and there is a lot of morbidity, like they don't become community ambulant after hip surgeries. They need support system. They need to have domestic help. So we need to treat osteoporosis to prevent fractures in elderly and to give them a better quality of life. Now, BMD is a good marker for osteoporosis diagnosis and follow-up. FRAX gives a good guideline about prediction of fracture for next 10 years, and the current drug recommendations, if followed properly, like bisphosphonates on empty stomach, then selective cases, those who do not have any breast cancer in family or they do not have any problem of gynecological issues, they can be given raloxifene, but hormone substitute in women is getting, it's not becoming very popular, means it's reducing its popularity. So we have in our armamentarium bisphosphonates, also calcium and vitamin D. Then the second will be in female gender, in specific female gender group, raloxifene. Then calcitonin if there is a fracture, and of course teriparatide. Now we need to have drugs which will directly work on the basic pathophysiology of osteoporosis. Thank you. Want to take questions?
Audience, if we have any questions for our speaker.
Medications, especially pioglitazone and glitazones, they also lead to the osteoporosis on a higher side. PPIs, I think they should be used a little bit with caution in the elderly people, because we have seen many prescriptions, there is a PPI. Any antiplatelet drugs, any of the aspirin patients, they are coming with PPI as a combination in the formula. So how often do you see osteoporosis so common in the PPIs? Because most of the orthopedicians, they also do write the PPIs with most of the NSAIDs.
Yeah. We are the most abusers in the world. See, this is the only unfortunate country, not even in Pakistan, you get any drug without prescription. So till the time we stop giving drugs to patients without prescription, this is going to continue. Now there are now adequate patients with physicians, those who are taking PPI over 5, 6 years. Now regarding orthopedic surgeons, they abuse PPI because they abuse analgesics. We don't have any other tools because we have to treat the symptom. Nobody want to understand about the philosophy of disease process. Now, unfortunately, people don't go to doctor back and keep continuing taking medication. So I agree with you that PPI definitely plays a role in osteoporosis, but there are some other factors additional to that. Not only the isolation of PPI. If you get a very fit athlete who is consuming proteins, having sun bath, jogging for 10 kilometers and taking popping a tablet of PPI, probably he might not get osteoporosis. So there are multiple factors which are responsible. Like PPI and low vitamin D is a bad combination. PPI with sedentary lifestyle is a bad combination. PPI with sleeping pill also is a bad combination for osteoporosis. Yeah, see, current guidelines about teriparatide is 1.5 years. So you need to calculate your bone turnover index before and then 6 months after that. If the bone turnover index is improved, your PPI or your teriparatide is working well. And then you need to continue for 1.5 years. Then you should keep a watch on DEXA and then repeat it. Current recommendation is 1.5 years. Yeah, you can repeat. Yeah, there are few side effects of teriparatide. Few patients feel hot flushes. Then, very unfortunately, teriparatide is started without understanding anything about parathyroid hormone mechanism. So, before you start PTH in any patient, you should always do parathyroid estimation, because many of your patients have secondary hyperparathyroidism. And to secondary hyperparathyroidism, if you give PPI, if you give teriparatide, they deteriorate. So primary hyperparathyroidism is a different ball game. Secondary hyperparathyroidism is very important. So first, that secondary hyperparathyroidism should be treated by high doses of vitamin D or understanding about whether there is a renal affection or not, and then teriparatide should be started. There are many patients those who deteriorate after teriparatide because their primary PTH value was high. Not to the extent of primary hyperparathyroidism, but secondary hyperparathyroidism. And there is some condition now, it's tertiary hyperparathyroidism. So if the patient has hyperparathyroidism and symptoms of osteoporosis, we should avoid giving them teriparatide. Nowadays, there is no primary recommendation for estrogen therapy. In West also they are not primarily recommended. Raloxifene is being recommended, but it has a limited role. So like they have to register themselves, get their mammography, pap smear every 6 monthly. So it's better to avoid in Indian population because they are not that much, because osteoporosis risk is lower than developing a breast cancer risk. So at least in India we should not primarily recommend estrogen therapy to women unless they are very affluent, they understand. Even transdermal creams, vaginal creams, shots, oral, all should be discouraged. They might be given by supervision of a gynec for their other symptoms like dryness of vagina or hot flushes or for time being, like psychological changes, but not for osteoporosis in long term.
How many days, according to the age-wise patient, we should continue the vitamin D3, and what is the marker when you stop the vitamin D3? Or you to continue with the still last breath?
You should burn yourself at least 15 minutes every day, 50% body parts exposed. If you are not able to do that, at least 1000 international units per day, lifelong. There is no dietary source. We do not have enriched food by vitamin D, which is very popular abroad now. Like in Australia, you get cheese, which is only fortified by vitamin D. You get milk, which is vitamin D supplement. So unfortunately, that's not customary in India. There are guidelines which are going on. There is a good research going on B12 enriched. It's the research is done in Cornell University. It is funded by Tata. So you get the Tata Cornell scholarship to in agriculture. They are developing grains fortified by B12, and they are introducing food atoms which will be high in vitamin D, because that's a very important issue in India. Thank you.